This is the Dental Up Podcast, your daily source for insights from dentists and leaders in the industry. Brought to you by Keating Dental Lab, a full-service, award-winning dental lab that is here to add value to your dental practice. With high-quality restorations, friendly, reliable service, the best products and prices, come experience the Keating difference. Visit KeatingDentalLab.com for details.
Good morning, and welcome back to the Dental Up Podcast. I realize it's been a while since our last episode, and I apologize for that, but my goal this year was to put out really meaningful content, not fluff. And to that end, today's guest is going to blow you away. He's an icon in our field, someone who every dentist in Southern California has come to know and trust. He has devoted his life to treating patients and teaching other dentists at the highest level. He's the founder of Regenerative Solutions, a practice limited to periodontics and implant surgery in Fullerton, California. He has authored over 30 peer-reviewed scientific articles and published 3 textbook chapters for dental students. He has also presented over 100 lectures both nationally and internationally. Please join me in welcoming to the Dental Up Podcast, Dr. Don Clem. Dr. Clem, good morning, and thank you for taking the time out of your schedule to help educate the Dental Up Podcast team.
Thank you, Robert. Thanks for the opportunity to talk about a subject that is quite often confusing.
It is. It's confusing, but it's very important. And it's a topic that I think continues to frustrate clinicians, patients, and technicians alike. We're going to focus on peri-implantitis. So let's begin. How is peri-implantitis defined? How do you reach this diagnosis? And how does this differ from peri-mucositis?
So one of the things that we look at specifically with dental implants is we were, I think, and to a certain extent, sold a bill of goods. We were told that implants look and feel and function just like natural teeth, and they are a lifetime solution for missing teeth or teeth that are going to be lost. And one of the things that we counsel patients on and dentists when we talk about dental implants and we make the decision to involve the patient in dental implant treatment is that really implants are not a replacement for teeth. Implants are essentially a replacement for no teeth, and they should be thought of as a medical device. And we know from the orthopedic literature that while medical devices are extremely predictable and they have a good long-term success to, for example, take a patient in their 30s and they ask me, how long will an implant last? Can I honestly look at that patient in the eye and say, if your life expectancy is 80 or 85, this implant will last you 50 years. And I think dentistry to a certain extent has gotten itself into that conundrum. We've been taught in dentistry at a very early stage in our career that once we do quote unquote permanent dentistry, that if anything should go wrong in the future, it's either the dentist's fault or the patient's fault. And we've bought in to that mantra. And I think it's caused a lot of confusion. It's caused frustration, and it's caused disappointment for clinicians and patients alike. So if we look at dental implants, the term peri-implantitis has been coined in terms of bone loss around implants. What I tell patients is that you're my patient today, but in 10, 15, 20 years from now, you are not the same patient. Patients are clearly living longer than ever before, but they're living longer with more chronic disease, taking more medications than ever before in our history. So if you look at dental implants and you look at bone loss around implants, that's the primary definition of peri-implantitis is bone loss around implants. But that term in itself can be overly simplistic. In approximately 2019, the American Academy of Periodontology and the European Federation of Periodontology came together to see if we could develop a more workable definition for clinicians to evaluate what the extent of peri-implantitis around their patients. So the definition that is currently used is that in the absence of historical data, an implant that has greater or equal to 6 millimeters of probing depth and greater or equal to 3 millimeters of bone loss is considered a lesion of peri-implantitis. I'd like to emphasize that the historical data is very important. It is not uncommon for implants to have bone loss. It is not uncommon for some crestal changes around implants to occur. That doesn't necessarily mean that implant has peri-implantitis. It may be crestal bone loss that has occurred from surgical healing. It could be bone loss that occurs from stress shielding with an implant undergoing great loads in the posterior part of the dentition. So clearly, there are three segments that you would define as peri-implantitis. Probing depth greater or equal to 6 millimeters, bone loss greater or equal to 3 millimeters, and bleeding upon probing. The bleeding upon probing issue has also been an area of confusion and misinterpretation by dentistry. There are two areas that affect implants. What is called perimucositis, which is parallel to what we would think is gingivitis, and peri-implantitis, which can be thought of as the parallel to periodontitis. So in perimucositis, we can have inflammation in the soft tissue around the implant. We can have probing depth due to the swelling of the tissue around the implant, and we can have bleeding around the implant with probing. We routinely probe our implants at periodontal maintenance procedures with a metal probe, I might add, with lighter probing pressure than you would around natural teeth. And that is how we define our lesions of perimucositis, which really focuses on the inflammation in the soft tissue around an implant, and peri-implantitis, which really focuses on bone loss around the implant.
Wow, that's a lot right there. And I appreciate you clarifying the difference between peri-implantitis and perimucositis, as well as putting a numeric quantifier on that. It's very important, and you addressed it there. Crestal changes, some of that may be normal remodeling, some of that may be related to load. What about implant design? Are there any features of implant design regarding threading, coating, smooth
No.
collar design that you have seen that may lead to a higher percentage of peri-implantitis?
So one of the things that in my career, I placed my first implant in 1983. And we were trained at the University of Texas, San Antonio, which was the first United States training center for the Brandemark technique. And Professor Brandemark actually came to the university, and that's how we were trained. And the implants that we initially used were machine surface screw implants. They were what would be termed smooth surface or machine surface. And while we did see crestal changes around these implants, I must tell you that from a clinical perspective, I'd not seen the massive areas of bone loss and vertical defects that we see around our current implants. And that has to do, I think, partly with implant design. It has to do with implant surface texture, and rough surface texture is rough. And you will have companies that will present data that said our implant surface is not as rough as our competitor's implant surface. But I have to tell you, nothing is as smooth as a machine surface screw implant. And we tend to see greater complications long-term with these types of implants if they're not properly designed and they're not properly maintained. The other aspect that one has to consider is as we've moved through the 80s, 90s, and the 2000s, we've moved off of the traditional long-term success of multiple implants in edentulous patients, and we've adapted these implants and designs to the partially edentulous population and aesthetic regions, which require implants to be placed deeper. They require implant designs that have internal fixations. And of course, they achieve greater loads and are more difficult to maintain in terms of plaque control in posterior areas of the mouth. So I think it's a multifactorial issue with regard to implant designs and how they hold up long term. I will also say that in terms of implant maintenance and what causes peri-implantitis, there are really two schools of thought. The one school of thought says that this is really a foreign body reaction. And the other school of thought says, no, this is really a bacterial infection similar to periodontitis. And over the years, I've come to the conclusion that it's really a little bit of both. So we must always remember that just because a substance or a device is what we would term biocompatible, that does not necessarily mean that device is impervious to foreign body reaction. And in fact, any implantable device or material that is deemed biocompatible that is placed in a patient's body really undergoes and continues to have a low-grade foreign body reaction that is essentially controlled. It is, of course, when we have an uncontrolled episode of a foreign body reaction that problems ensue both with soft tissue and bone loss. It becomes difficult from an etiological standpoint to determine which came first. Did the uncontrolled foreign body reaction come first and then the bacteria came to enhance that? Or did the bacteria come first and the infection ensue and then the foreign body reaction contributed? And I don't know that we really have a clear literature-based answer to that question. What I do know is this, that if we can control the bacterial infection in peri-implantitis, many times we can control or limit the progression of the disease and keep implants that previously we thought were untreated.
Clinically, that's what it's all about, is managing the situation, managing the patient's disease, and whether it's bacterial infection, foreign body reaction, which came first, clinically, it's going to manifest as the same issue. So how do you treat it? How do you help the patient maintain this implant and get longer years of service out of it?
Clearly, as a specialist, my practice is primarily referral based. And the one key that I can give clinicians, whether they be general practitioners or hygienists, is that early diagnosis of both perimucositis and or peri-implantitis is really essential for treatment. And we have to look
Can I ask a quick question?
Sure.
What is the percentage of cases that begin as perimucositis that then develop into peri-implantitis?
That is the question of the day. And it is generally accepted that perimucositis is a precursor to peri-implantitis. But again, we don't have the data to tell us what percentage that is. We know, for example, however, that in periodontitis, just because a patient has gingivitis does not necessarily mean that that gingivitis will progress to periodontitis. Even though periodontitis is a very common condition, gingivitis is an even more common condition. And so we look at the conversion between gingivitis going into periodontitis, and clearly gingivitis is a prerequisite for moving into periodontitis. We believe, therefore, that perimucositis is indeed a prerequisite before moving into peri-implantitis, but we don't exactly have the data to tell us what the risk is and what the percentage of that is. There are, of course, multiple factors that come into that play. For example, we used to believe that lack of keratinized tissue around implants was unimportant, was non-contributory to progression of peri-implant disease. And our thinking has now changed in terms of the amount of keratinized tissue and thickness of soft tissue around implants. We're currently doing a randomly controlled clinical trial looking at older implants, and as implants age, the soft tissues around those implants tend to thin. And as those tissues thin, we see an increase in inflammation, difficulty of the patient attempting their own plaque control, difficulty in maintenance due to sensitivity and tenderness around those tissues. And so the importance of soft tissues and the thickness and the status of the keratinization around those tissues becomes important. We don't really know what the conversion rate of perimucositis is to peri-implantitis, but clearly, once the diagnosis of perimucositis is made, then early treatment is really indicated.
What are some of the early treatments that you're advocating for your referral base, both your hygienists and your clinicians? What's your advice on how to treat perimucositis?
So with perimucositis, we have to think of it as aligned to gingivitis. And so it really starts with the diagnosis and treatment planning of how we're going to restore this patient from a restorative and from a surgical and restorative standpoint. From a surgical standpoint, we need to choose an implant that can be maintained easily, that choose implants in appropriate locations. One of the issues that we have in the aesthetic region, for example, is that we very seldom will actually recommend or treatment plan multiple adjacent implants in the aesthetic region. When we do that, we typically find that the papillae between those implants will flatten out. It's very difficult to position those implants so that they can be restored aesthetically. It puts handcuffs on the laboratory technician because he or she is now put in a position where they have to close embrasure spaces and now becomes a plaque control issue for the patient. So the management of perimucositis is most effective when it's treatment planned and surgically and restoratively executed correctly. Now, having said that, once we have an issue of perimucositis, that's again diagnosed by bleeding upon probing, gentle probing, we have to look at, first of all, what is the patient doing in terms of their own plaque control? How can we affect plaque control? And again, how can we help in terms of what the patient uses on a daily basis? Secondly, for perimucositis, careful debridement of the implant and restoration is often indicated. And our hygienists have a protocol in our office, which we use, which includes rubber points instead of rubber cups. It includes easily dissolvable polishing powders and substances. It includes some irrigation with antimicrobials. And in isolated cases, we actually use local delivery antimicrobials, such as minocycline microspheres, in those regions to decrease inflammation and decrease the plaque load. One of the other issues with perimucositis is that many times it can be corrected with soft tissue augmentation as well, and that requires some additional diagnosis and treatment planning.
Sure, grafting. Now that we've covered perimucositis, I want to get into the main topic, peri-implantitis. What's your recommendation for a general practitioner that is really facing this issue for the first time and they're a little bit unsure as to what to do?
Again, peri-implantitis, now we have bone loss. So now we have a typical lesion that has 6 millimeters or greater probing depth. We have radiographic evidence of bone loss. One of the issues that becomes frustrating is that we've been taught in dentistry to use standard bite wing films, horizontal type bite wing films, so that we could do what? We could look for decay. I've yet to see an implant that's decayed. So really, vertical bite wings, if we're going to take quote unquote checkup films, if a patient has dental implants, particularly in posterior segments, vertical bite wings give us a much greater picture in terms of that initial occlusal third of bone around implants. Once an implant has been successful and once the implant has been integrated, many times even my assistants will come to me and say, I have a radiograph of the implant, but I didn't get the apex. Similarly to how implants never decay, I've never seen an implant that has a root canal problem either. So really, it's that first third of bone that we're really interested, crestal bone. So once that diagnosis is made, if they have what I would term early peri-implantitis, it often involves significant inflammation of the soft tissue. And I would tell you that local delivery antimicrobials with minocycline microspheres can be an option, along with careful plaque control instructions for the patient and follow-up. One of the things that dentistry has been loath to do is follow up on a timely basis. So once I make a diagnosis of peri-implantitis or periodontitis, and the patient is, say, initially treated in the general practitioner's office, typically that patient won't be seen again for 3, 4, maybe 6 months. And essentially, that patient should really be seen in 6 weeks to reevaluate how successful their treatment has been. Based on that reevaluation, then either additional treatment and or referral should be done to a qualified specialist. That I have to tell you, that's one of my other frustrations that I've had in clinical practice. There are some surgical specialists who will have the philosophy of, if it's somebody else's implant, I don't want to see it. If it's my implant that I place surgically, I'll see the patient. But if you, Mr. General Practitioner, have an implant patient that you've inherited and the implant's been placed by a surgeon other than me, I really don't want to see it. And I think that's advocating our responsibility as specialists. And I truly believe that as specialists, we need to support our referrals in their successes, and we need to support our referrals in their failures. And many times what's happening now, if you think about it, there are over 3 million implants placed yearly in this country. And if you even go on the low end and you say that peri-implantitis will affect 10 to 15% of those implants, which is really a low estimate in the literature. So let's take 10%. I have to tell you, 3 million implants are being placed in this country, and only 10% of them at the low end acquire peri-implantitis. You're talking about over 250,000 implants in this patient in this country that have peri-implantitis. So as a specialist in bone regeneration and soft tissue regeneration, it becomes incumbent for me to address that issue and to participate in treatment, whether it's my implant or somebody else's implant. Ultimately, it's the patient's implant. And our responsibility is to treat patients. That's how we address that issue.
Absolutely. We all work for the patient. Even as lab technicians, we work for the patient as well. And it's a very honorable position you take. It's so important because, especially in this early time period, it's like everything. And, if you recognize the problem early, first is the GP has to recognize that there's a problem and recognize that it's a serious issue. And then, therefore, you can treat it appropriately. You mentioned also the point of surgeons not wanting to take on the responsibility of others who have placed a fixture in the mouth. And again, that goes back to, we all have failures and we all should be learning from our failures. It's such an honorable stance that you take. And hopefully, I know for certain you've been able to educate many of the other providers in Southern California that have encountered this problem.
Well, once you have the problem, then you have to look at, when I see that patient in my office, you have to look at several factors.
Thank you for listening to the Dental Up podcast, your daily source for insights from dentists and leaders in the industry. This episode is sponsored by Keating Dental Lab, here to add value to your dental practice. With high-quality restorations, friendly, reliable service, the best products, and prices, come experience the Keating difference. Visit KeatingDentalLab.com for details.